Good afternoon. I think we better keep people amused, haven't we? Marcella, how did you manage your surgical job on the cutting down? Yeah, that happened to me once, you know. It happened to me once. Gosh, you didn't panic. I panicked when I had it. Big challenge. I can't hear you actually. You're mute.
It's interesting, isn't it?
Yeah, that's the way it is. Are you in Spain at the moment?
No, I am in England. I am in Sidmouth.
You're in England. God.
Yes.
It looks so beautiful there. I thought you were on a cruise ship or something.
No, this is basically a very, very small town in the south of England. You know Devon? In Devon, there are little villages, and this is one of the coastline villas, basically.
Oh, you're overlooking the G7 summit, are you?
Exactly. I'm keeping an eye on them, trying to make sure that they are behaving.
Yes, absolutely, particularly Johnson.
Exactly. He looks a bit confused in some of the photos.
He looks tired, poor man.
Yeah,
He's been working too hard.
Yeah, I
He's
think
working
so.
hard. It's a hard job, isn't it? But you got to do it well.
Yeah, you are right. It's just incredible because it's not like a 3 months problem or 6. This is almost 2 years.
Yeah, we are live now.
Good.
We are live. So we're being streamed right into the G7 summit, Marcella. You'll be pleased to know.
So.
Thank you, Himanji, for that very kind reminder. I did think so.
Thank you. Sorry.
Well, I look forward to your talk. You know, it's a great talk, really, because that's what every country has been very stressed about.
To be honest, I think that it's all about sharing experiences and seeing how we can do things together. I think the pandemic taught us something different.
Have you got me on the video or not?
Iqbal, you're not there on the video, no.
You can see me.
No.
Good. Yeah. Same. I can't see myself, but I've got the video on. I can see all of you others.
You might have to log out and log on again, Iqbal.
Should I try that?
Yeah, I would do that.
Yeah.
Still got a few minutes. How are we doing for time, Deep?
It's 1:33 now, 34.
Yeah, we should start because Iqbal will join us, I'm sure.
Yes. So who is going to kick off? I think that was.
I think Deep, right?
Yeah.
Yeah. Dr. Divatia, yeah.
So Deep has to kick off.
Yeah, you can kick off. I'll speak without the video if that helps. If there's a problem. I can give one more go if you want. Have you got a minute? I'll try again.
Can we make sure that we all can share our screens? Because at the moment it's disabled.
Yeah, there's only you that's going to do the slides, Marcella. None of us.
Yeah, but I am disabled apparently.
All right, you need to be enabled, yeah. So
yeah, I am now. Thank you.
Yeah.
Perfect. No, just double checking, the last minute panic.
Yeah.
Well, hello everyone. I hope you can hear me.
Yep.
Yep.
Yes.
Perfect. let me welcome everyone here and our participants. Dear participants, I, Deep Narayan, would like to welcome you all in the UK-India Clinician Knowledge Exchange Series. This is one of its own kind, where top experts from NHS England will be sharing their knowledge and experience in the most burning topics that are desired by Indian clinicians. I'm delightful to share that we will be holding these sessions on every Saturday, 6 p.m. and open Q&A sessions on every Thursday, 6 p.m. We encourage all of our Indian clinicians, medical students, and other medical professionals working in the forefront of COVID management to participate. You can ask questions using the YouTube chats. In the interest of time, I'll welcome you all once again and move ahead with the introduction to our guests, speakers, and panelists. At first, I would like to welcome Dr. J.V. Devatia, Professor and Head, Department of the Anesthesia, Critical Care and Pain, Tata Memorial Hospital, Mumbai. I would request Dr. Devatia to open the session and introduce the topic of today. Over to you, Dr. Devatia.
I can hear you, yeah.
Good evening, and thank you very much for organizing this extremely innovative series
Sorry,
of
what did you say?
sessions on along with the NHS of England.
Yeah.
Now, today we are going to speak on a very important topic, and that is on best practices for ICU resource utilization during the COVID pandemic. Now, we've been hit by this pandemic along with the rest of the world, and I think we've taken a bigger hit in the last month or so. And one of the things that has stood out right from the time this pandemic began was that this was going to be a sort of respiratory illness, at least initially to start with. And we would be requiring oxygen support and ventilator support. And the focus shifted from, suddenly there was a spotlight on intensive care and ventilators. This exposed a lot of inadequacies in our system in the sense that, we needed to have more ICUs in the public sector, because we had a concentration of ICUs, very good ICUs in the private sector, but we needed to come up in the public sector. We needed staff to handle the ventilators and handle critically ill patients, which was not very easy to find at short notice. So we had to come up with innovative strategies to do that with the help of our own innovations, with our help from our colleagues in India, and very importantly, the recent surge from help from our friends from the UK and other countries, we've sort of managed to cope. But I think while we talk of surge capacity and how to expand ICUs, how to expand our resources and how to optimally utilize them, I think at one stage, there's only a certain amount any hospital system or a national system can accommodate, right? Even in the first wave at the peak, we had 97,000 patients per day. Today, at this time at the peak, we had 5 times as much or 4 times as much. And next wave could be 10 times as much, but you can't keep planning for 5, 10 or infinite proportion of times. I think the best way is to try and keep COVID in the community and not let it progress. Prevention, of course, but we should also try and keep it restricted to the community and not reach the hospitals if we can. And if it reaches the hospital, we should try and treat the patients well so that they don't reach the ICU, so that at every step, if we can cut down the number of patients who require specialized care, we can actually do better for the patients as well as for our healthcare system. And I think that's something which we have to learn and which we have to sort of get our systems in gear so that the right patients reach the hospital. In the hospital, the right patients reach the high dependency units, and the right patients reach the ICUs. And then they get the best treatment that they deserve at that stage of treatment of their disease. So I think we've got a lot to learn from each other, and we've learned a lot from the UK. I think the recovery trials and many of the publications, the vaccines have been outstanding. And today, I think we've got an outstanding series of a lecture and outstanding panelists who will take us through how we can utilize our resources very well. I'm really looking forward to hear from Dr. Marcella on how they have got a very innovative system and how they are going to manage the COVID patients in the hospitals and in the community. So I think I'll hand over to Deep, and we can progress with the rest of the session.
Thank you so much, Dr. Devatia. It's so great to hear from you. Now, I would request Dr. Iqbal to introduce, speak about it. But before that, let me just give a quick introduction about him. So Professor Iqbal Singh, OBE, he is joining us as a panelist for the discussion. He's a consultant physician in medicine for older people. He is a leading contributor to healthcare and medical regulation as founder commissioner, Healthcare Commission. He was council member GMC 28 to 2012 and was a member of the review group of good medical practices. He chaired the Healthcare Commission Expert Reference Group on patient safety, developing standards of assessment of safety in healthcare. He is a member of National Committee Advisory Committee, Clinical Excellence Award, and the National Platinum Award Committee, and founder, chair of the Center of Remediation Support and Training. Now, if you can hear us, Professor Iqbal, over to you.
Thanks very much, Deep. I'm
Yes.
sorry we are having some difficulties with the video, but really a great pleasure to be amongst friends here today. And I would say that, COVID has had a huge impact globally, as Dr. Dwatia was saying. But in India, over the last 2-3 months, these have been really challenging times. The UK Indian doctors, the Indian diaspora, NHSI led by Pradna, BAPIO with JS and Ramesh and many others. So many of us have made so many amazing contributions in different ways. One of the major discussion topics when we have spoken to colleagues in India is the need to set up a forum for exchange of knowledge, for sharing of knowledge. And therefore, I would say to you, Deep, to NHSI, to the Foreign Commonwealth Office, to the Tata Hospital and Dr. Dwatia, this is really a great initiative. You're doing a great job. And I hope that this becomes much more a permanent feature. And we're talking well beyond after we moved past COVID. The other thing I wanted to share with you was that in UK, there has been a huge disproportionate impact on BME clinicians, BME health work, BME communities during this period. Staff have been working and they are strained. And what we really need to remember is we need to develop a culture that we can support healthcare staff. And I know Dr. Marcella will talk about it and JS as well, that we are able to recognize, we are able to thank them. And you'll all be pleased today. It is the Queen's official birthday in UK. We've had the awards given to some of the people here, and that is to one of our colleagues here, Imanji. Congratulations. But it is recognizing people. I'm a part of the honors system, and we've recognized people that helped develop the vaccine from AstraZeneca. And what I would really say is we need to be grateful, we need to recognize, we need to support the doctors that have been through, we need to support each other. But more importantly, can we please make sure that we also look after ourselves, because very often we forget to do that. And with that, I pass you back to you, Deep. Thank you very much.
Thank you so much, Professor Iqbal. Great to hear you. Now I would like to introduce Professor J.S. Bamra, CVE, who is joining us as a panelist. He is a senior consultant psychiatrist at the Great Manchester Mental Health Trust, visiting professor of psychiatry at several universities in India, and an honorary reader at University of Manchester. He's a writer, researcher, and a speaker. He's a chairman of British Association of Physicians of Indian origin, which is also known as BAPIO. Over to you, Professor Bamra.
Thank you very much, Deep. And I'm very, very grateful to you all for organizing it, particularly Prerna Isar, Rais, and Naeem Ahmed, who isn't here, but their thoughts are with us all at this challenging time. And I'm looking forward to Marcella's talk because she's such a well-known intensivist, and lovely to be here again with my esteemed colleague Iqbal and Dr. Dwatia. So, look, I thought I'd tell you a little bit more about BAPIO. So the president, founder of BAPIO is Ramesh Mehta. He sends you all his greetings and his love. And BAPIO is 25 years old this year. And we are an organization not exclusively Indian, although our origins are in India, because we have championed the cause for diversity, inclusion, equality, all of that sort of thing for the duration of the time that we've existed. And during COVID, we've obviously had to play a very different role. We've raised funds for the COVID India appeal, and we've had a three-pronged approach, in fact, four-pronged approach, if you allow me. One is that we would send all the equipment that we could, oxygen concentrators, ventilators, masks, that sort of thing, sanitizers, to India, to particular parts in India, particularly try and get them to rural India, especially pulse oximeters. And we've also raised funds for food for the needy and distributed it through local charities, including Akshay Patra. We've had a third very important arm, which is teleconsultations, which is actually fronted by Professor Parag Singhal, physician, who's been linking up with various institutes in India. If anybody's interested, let us know, doing virtual ward rounds and supporting our colleagues at this particular time. And our fourth approach has been to write to the Prime Minister here to say that vaccines should be free of charge in all developing countries, and developed countries should pay for it. Nothing more than that. And I hope that they do. Now, I'm going to tell you afterwards, hopefully in the panel discussion, what is really precious to me, which Marcella will hopefully talk about, which is mental health. And mental health has a particular role, not just for the patients in ICU, but also for the carers, who are the intensivists, who are the anesthetists, who are the surgeons and the nursing staff, and all of them who come in to help people out in ICU, because we've seen an increase in depression, anxiety, insomnia, but also an increase in a moral injury, which I think Marcella might talk a little bit about, but I'd certainly be happy to talk about in the Q&A session. So I look forward to the talk, and I look forward to any issues. Obviously, I'm not an intensivist, but there's no health without mental health, and so I will talk about mental health in the Q&A sessions, if you allow me. Thank you very much, Deep.
Thank you so much, Professor Bamra.
And we can see Iqbal.
Yes, we can. Thank you so much, Professor Bamra. Now, before I hand over to Dr. Marcella, let me quickly introduce her. Dr. Marcella, she is an honorary clinical senior lecturer at Imperial College. She is also a consultant intensive care medicine at Chelsea and Westminster Hospital. Now, Dr. Marcella, over to you for your presentation. Thank you.
Thank you so much. Thank you, Professor Bamra. And as you clearly said, the brain is the forgotten organ, and all the suddenly here we are discussing about it. So yes, the pandemic made us think about it as well. So thanks, Dr. Iqbal and Dr. Davatia and the organizers for inviting me today to share our work, and hopefully here. So as we all know, the pandemic started a few months ago. It's practically 2 years if we think about it. And another fact is we are fully aware of the complexity of an intensive care unit. And this picture is just to illustrate what a bed space in intensive care looks like. And this is in non-COVID times. So you can imagine how it is when the number of patients increase dramatically. So one of the key points when we talk about living in a pandemic, we talk about family and home life. We need to think about work colleagues and, of course, our patients and relatives. And this dynamic is fluent and varies at different points of the pandemic. To start with, I would like to share with you one of the most important pictures of our unit when we organize our nurses and start getting them ready to look after COVID patients. This is a photo that was taken during the first wave. And one of the things that struck me the most about this photo is their smiles. They put a brave face and they were ready to look after patients. They were probably scared, but they didn't share it. They felt it was their duty to go there and to do their best. And the photo on my right, when we are all in blue, in our blue gowns, you can see the faces again. That was the day that we discharged our last patient from the intensive care unit following the second wave. The team was exhausted. Still, expression of happiness, not happiness, but satisfaction that is a mix with exhaustion. And so there are quite contrasting photos that we must not forget through the presentation. So I will take you back to 2020, February, when we knew that due to infection with SARS-CoV, a novel coronavirus commonly causing death, that was first identified in China. Probably all of you remember the 3 cases published in the New England Journal of Medicine. And following this work was a work by generated in China as well, published in a peer-reviewed journal with 196 patients. And the stat showed at that point that older age, multi-organ failure, and high D-dimer, that is a marker of blood clots, were the risk factors for patients in hospital. So with that in mind, I thought that there are the 3 clinical conditions that lead to high proportion of death in COVID patients. So that was shown by papers published by our colleagues from China and also by our colleagues in Italy. So there were 3 leading causes of death: thrombosis, cytokine storm, that basically is a massive inflammatory response, and severe respiratory failure that may or may not be associated with infections. And so my point by March that last year was, if patients progressing towards these endpoints were identified early, then that would enable us to target their management. So by that, we could potentially improve their outcomes. So that was reported. The data was there. It was up to us how we use that information to look after our patients. So the aim was how we use that information to manage our COVID patients. How could we change our working practices to be more responsive? It's true, by March 2020, we didn't have many cases in the UK, but we knew what was going on there, and we knew what was the leading cause of death. So looking into the informatics system, we normally get a patient that is attached to a monitor, and the information, that is physiological variables, plus the EPR system, that is electronic medical records, blood results, radiology studies, fit into a system where we can start modeling. By modeling, we simulate the clinical condition that the patient suffers from. And by simulating these results, we can actually calculate the risks of preventable complications. And by calculating the risk, we could advise clinicians that will modify treatments and then recheck again. With this slide, what I want to highlight is that looking after COVID patients was not only about us front-end physicians, was about utilizing the forces people from the organization, like the clinical informatics team, utilizing the resources from clinical engineering, the states, because they know about the tank of oxygen and the replacement of oxygen in our organizations, was to try to get every single piece of the puzzle together. So the data mining, how we started doing it. What is data mining? And basically, we started gathering the information when we were examining patients. So it's a simple mind. So we have to decide how we create a system that clinical specialists and non-clinical specialists, including non-clinicians at all, understand the same language. Because if we needed help, we needed to stratify a system in a way that allow us all to understand what we were talking about. So based on clinical examination, I identified the clinical variables that may dictate change of management of those patients on arrival to the emergency department. That was the key. Patients arrive to ED, some patients are sent home, some patients don't manage to arrive because we're too ill, and there are three groups of patients, that are the green, the amber, and the red, that may be admitted into hospital. And the severity will depend on the changes on the variables. So with this in mind, we started processing the data. And we identified 40 patient-specific variables that we used initially to run the neuronal network algorithm. And straight away, we identified that early patterns led to the selection of 11 input variables for the model. And you may be wondering, why was that so important? What does these variables have to do with intensive care? And actually, a lot, because allowed us to identify the patient's risk at the point of entry to hospital. So at that point, we found that the CRP was identified as the single more powerful marker to discriminate blood clots in real time at the point of admission to hospital. And that actually supported by findings by other colleagues abroad from post-mortem examinations. So by March 2020, where we got data from China and Italy about the commonest cause of or leading causes of death, we got post-mortem examination telling us that patients were dying with clots somewhere in the body. So we identified the CRP as a single marker to discriminate patients with or without clots. We identified the ferritin as a solo marker to discriminate patients with a cytokine storm, and was a very complex to identify a single marker to classify patient risk of respiratory failure or secondary infection. That came a bit late. So with that, we created a system where we identify the thromboembolism, cytokine storm, ARDS, and no flags, mild flag, medium risk, high risk, and suspected with the variables. And why not confirmed? Confirmed thromboembolism is a bit too late. Confirmed cytokine storm is a bit too late. So we focus in the group of patients that we could do something about. So with that, we set up like a control command where the site managers, nurses, and people with basic knowledge of medicine but full understanding of the classification were in front of computers and looking at this traffic light. And every time that a patient flagged for high risk or suspected risk, they picked the phone and notified clinicians so they could change management. Because remember, the demand is extremely high. This is an anonymized view of our dashboard, where we split it by hospital sites, by ward. We could identify patients by age group, suspected of COVID, latest or last COVID status. So at a glance, we could see the number of patients with COVID on different wards in the hospital, and also patients' age and gender. And it was vital because from the operational point of view, allowed the managers and the admin team to search for resources depending on the number of patients in the system, by location of patients by gender. So operationally was thumb up. Clinically, when we look at patients' level, you can see on this simple screenshot, we could see the patients that were suspected, high risk or medium risk. At a glance, in one single dashboard, we could see the patients, the different risk level categories. So people could be, physicians on call were communicated in case they were busy reviewing patients, so changes could be made on the prescription records or a request for a CT scan in the case that a patient move from a medium category to a high category, for instance. But when you see the number 2, it's the oxygen use. That was a very important tab. You all have seen in the news and have experienced the lack of oxygen. And this is a serious business. So we done this at the very beginning. You know, this is March, at the end of March last year was in place. So we could track the number of patients on oxygen. Not only that, we can track the amount of oxygen that we were delivering. So that allowed us to calculate the consumption of oxygen per minute, per hour. And that information was used by the state so they could communicate with the lorries to deliver the oxygen. We knew if we needed oxygen every 3 days on one side, or every 5 days, or a day and a half. So allow us to not to think about oxygen, because the team was looking after this by using the information that is clinical information. We also knew the type of equipment that we were using for each patient. And this was used by the procurement team. So they knew about consumables. They needed to get for us and where, because we could get the location of the piece of equipment. And that helped us actually to run and look at the patients while the procurement team were keeping an eye on the consumable stuff across the organization. And remember, for ICU to function, we needed to make sure that the rest of the hospital was safe. We somehow tried to prevent progression of disease. This is a bit more at patient's level. Say you review your patient and you want a bit more of information, you can see the vital signs or the variables that discriminate your patient from one risk to another, and the type of ventilatory support. From the operational point of view, was the best things to do, but also from the reporting point of view, because the government need to know how many patients are in hospital, how many patients are ventilated. They needed to know how many patients were on oxygen outside the intensive care unit, so they could plan. So this system was somehow automated, so the reports to the NHS England were done by our informatic team. Again, we release the nurses from doing these tasks and allow the teams that got the knowledge of numbers to go through things. Following the first wave, we managed to get the second dashboard sorted. A component of the dashboard is about to predict the likelihood of ICU admission, needs of mechanical ventilation, or mortality of our patients. And again, this is from the point that the patients were admitted into the emergency department. So allowed the managers to plan nurses when they hit the value of 50% or above. So when the patients are very unwell, we know they need to go to ICU. I don't need anything. When the patients are well enough, they go home. It's the patients that were admitted into hospital, and we were not very sure if the patient will follow one path or another. So by having this as a backup, support as well the clinical decision. Unfortunately, we were a bit slow with this, and this came for the second wave. But it's a real-time system and gets updated like the other dashboard every 10 minutes. So it's dynamic. So, but did it help actually? This changed clinical practice. Did it help patients? What can we learn? So yes, we got the traffic light system to identify the 3 conditions, and that from the emergency department to the point that patients were discharged from hospital. So we flagged or identified the cohort of patients, that were at very high risk or developed thromboembolic events that we call flags, pulmonary flags. And yes, it's true, few patients at the beginning got cytokine storm. That was in the news. Everyone were worried about the massive inflammatory response. But what people were having as a main complication was thrombosis. So with this, allow us to actually somehow treat and manage them and support them and prevent progression. So we also saw the number of patients, the time that takes patients sometimes to deteriorate. We know that, for instance, we're medium to high risk, an average of 2 days, and around 5 days for patients that move from high risk to suspected category. So we could see in real time our patients, and because of that, we could actually treat them. Enhanced anticoagulation or full anticoagulation. And from the cytokine storm, there was no specific treatment. Yes, we talk about anti-inflammatory drugs, but for simple intensivist, a patient that has temperature 39 to 40 for 3, 4, 5 days, that's dehydrated. The intravascular is low. So those patients need to be hydrated, need to be supported, and somehow dump the systemic effect until the clinical studies show us something. Because remember, in parallel, we were running clinical trials across the country and worldwide. We didn't have any answers about a specific treatment. So the supportive treatment was vital to keep moving these patients forward. So did it prevent progression of disease? And you can see this was before our traffic light, number of patients discharged alive from the hospital, and post-traffic light. We can see that more than 75% of patients were discharged alive. Okay, it's sad because it's still higher than expected for a world patient, but survival rate was extremely high. And that despite of our patients being older than the pre-cohort. So clearly supported treatment, targeted supported treatment, help patients to go through the system. There was a net reduction of mortality of 33%. But what is most important, these simple strategies help people that were 68 or above, male patients, patients with COPD, patients with diabetes, patients with hypertension, all the risk factors that we keep mentioning on and on. So the initial steps are everyone business, nothing to do. So hydrate, self-proning, all the vitamins that need to be done, given to patients. In the emergency department, exactly the same, plus the oxygen, the antivirals, dexamethasone. And hospital admission, exactly the same process. What we see here, that as time passed by, we introduced the lateral flow testing in acute hospitals. That allowed to actually monitor closely our personnel and also protect our patients. We got the vaccine and level of evidence for the use of dexamethasone and remdesivir. So we reanalyzed the data for the second surge, and you can see that the age of the patients somehow is a bit lower, so younger patients got infected. The survival rate remains very high. I did a cut for this analysis at the end of November, and the rationale for that is because until then, we were not using dexamethasone or remdesivir. So the survival rate kept going up with supportive treatment, and I assume that with the new drugs, this number will be even better. And there is studies out there that the current mortality is the same as the expected one. So we are reaching the level that what is expected in hospital mortality, sorry. The same group of patients benefit from it. So what we can say that yes, we got our mortality was lower than the average. And that is not because we got a fantastic electronic system. That is because we got a team effort, a multidisciplinary approach to care. We share responsibilities. It was a consultant-led service 24/7. We have large number of consultant anesthetists. They were team leaders for tracheostomies, for central venous access, transfer patients, proning patients. Junior doctors were protected. We created groups of 6, and they were rotating. So they have time to rest, because junior doctors are the future generation. And we needed somehow to protect them and help them while they were helping us. It was very challenging. Nurses, and we tend to forget about it, are the ones that suffer the most in intensive care, because they were moving from band 6 nurse, needed to supervise, to 4 nurses that were in ICU when looking after patients. So the group of people that have a big impact or suffer from the pandemic are the nurses and the physiotherapists, the nutritionists or dietitians, and the pharmacists. They run very thin on the ground, and we somehow tend to forget about them. The pharmacists were vital to get drug A, B, C, D. You run A, you go the B, you go the C, you get the D. And those people were stretched, and those people will suffer in years to come. We got a family relations team, and that was consisted of consultants and doctors that were not providing direct clinical care because the clinics were canceled, because the dermatologist was not doing a clinic, or the surgeon was not doing the big surgery. So we redeployed them to the intensive care unit to read the records and ring families. So every single family was updated in a daily basis about the next of kin. We got the psychologist doing FaceTime with the relatives. We've got pads so people could see each other. Was a way of putting a human component to the pandemic, because we didn't have faces. Patients were waking up from the ventilator with no faces. So having the family on a phone, on a tablet, was of great help for them. So we also have a rapid development of a structured procedural guidance, and this is available to all. So even a non-ICU doctor could actually learn the ABCDE and deliver care. Everything was available. WhatsApp groups share via a special app that we developed, or the trust developed for us, and through the Ethranet, and printed copies at patients' bedside. So finally, it's about patients' relative experience. So patients are not to remember, but they have developed post-traumatic stress disorder. Our psychologists currently are following patients following 1 year post-ICU admission, and patients are very grateful. People are really grateful to be alive, but they are traumatized. And we can see that the relatives are the ones that suffer the most, because they were conscious. They were the one ringing or waiting for us to contact them. So these are the people that may have an impact on the recovery phase of our patients. And of course, our nurses, because at the end of the pandemic, or the second wave, nurses are exhausted. And I have to say that between the first and the second wave, we lost all our European nurses. They went home because they felt that that was the right thing to do. So clearly there is an impact. It was lovely faces, they were happy, but still not enough, because the pandemic made people think about themselves, which is right, but that in a way affects healthcare systems. And that is where we as a group need to decide how we can move things forward. These are comments from patients. I share the link with all of you, where people write lovely things, but nameless nurses or nameless doctors, because we didn't have faces. So for a nurse that is there by the bedside, and seeing the patient going through, but no memory of her, must be traumatic. So the challenges that face from staff reflection is anxiety, especially from the very beginning. Physical exhaustion, because if you were not looking after patients, you were on the phone ringing relatives, or you were on a computer your colleagues to inform them that patient X need to have a CT or need to have increase the treatment of anticoagulation. Was dynamic. Anxiety and pain. And I think this is extremely important. I remember when our Filipino nurses back in February 2020 said, Dr. Marcela, we want to help, but we don't want to live with our family, because we don't want the virus, we don't want our family to get unwell. So I talked to the charity, and the charity managed to get accommodation for all the nurses, so they could actually deliver patients' care and at the same time protect the family. Didn't like to be called heroes, because they feel like just doing the jobs. And it is an emotional roller coaster. It's upside down. And it's going to take time to get this. The positive themes, camaraderie and peer support amongst team. Is people approach, the good morning, good afternoon, how are you today, made a big difference. Feeling valued for roles. And in here, I said nurses and junior staff. But believe me, senior staff we need to congratulate as well, because they were there for us. organizing staff, the executives, the senior managers, the team as a team working together to help these patients. And we tend to forget about senior roles and what they have done for us. So seeing patients recovering from long periods when they were ventilated for a long time, of course, the meals, the goodies, the kindness of people, that and have a transfer team organized by the region. We got the Northwest London, got a transfer on call team. So if your hospital was saturated, patients that were safe were moved from hospital A to hospital B. And that allowed the flow of patients across London. So it has been very challenging. We were very thankful for all the support that we gained. We learned that thromboprophylaxis and early CTPA with CT brain was key. The identification of patients at risk in the emergency department, and be aware that it's not about the patients only, it's about the relatives, because they have been through the process. The patient remember when was taken by the ambulance and will remember when they wake up, but the relatives were through their process. We need to keep educating ourselves and be kind. We need to be kind to ourselves and to our colleagues. That's vital. So our conclusion 2, personalized early interventions were associated with the reduction in mortality. We suggest that early triggers to review enhanced anticoagulation management without exposing patients at risk. I thought that this slide is quite important to share because India has been through a lot, and despite of the restrictions, when we look into mortality per 100,000 patients, the position on the table, I think that there are around 26 people die per 100,000, while in Peru there are 500 plus. So the pandemic actually is still affecting South America and badly. So I am originally from South America and trying to support the same way my colleagues over there, but there's still a lot of work to do for us to level up. And with the vaccine, hopefully, I think that is the next level, I suppose. So the final thought, work in a group. Think about what resources you have. Don't think like a clinician. Think, I am a clinician, but who can be in my team that can help me to improve the outcome of these patients? And that's when you bring the state, clinical engineering, visualization, the academics, and together we can move things forward. So I'm sorry, I ran a little bit. I want to thank the entire team, Shell West and Northwest London, and all our colleagues. We tried, we have tried, we keep trying, but sometimes it's not enough. And that's one of the things that perhaps is the most painful of all, because we just don't want people to die of a virus infection or the complications, preventable complications of a virus infection. So I think that we just need to keep going and do what is best, look after our patients.
Thank you so much, Dr. Marcela, for such insightful presentation. Now, I would like to open the floor for questions and initially from the discussion. Over to you, Dr. Devatia.
Yeah, thank you, Dr. Marcela. That's a wonderful talk and an example of how you can combine medicine, bioinformatics, and organized structure to help your patients and to estimate your own requirements of various resources that you need in the hospital. And you showed us fantastic data as how it actually led to a much better outcome, even at a time when dexamethasone and all the drugs that you were talking about were not available, by just simple tests on the wards. And of course, it's a very sophisticated system, and hats off to you for pulling it off in such a short time during the pandemic. And I think you touched upon mental health. So I think we've got Professor Bhamra here, who's an expert in mental health. So Professor Bhamra, there are the patient who's going to be affected, there's the staff who's going to be affected, and the families who are affected. And as a sort of quick this thing, is there some way that we can decide who is more likely to be affected so that they can be targeted for psychiatric or psychological assessment and intervention? And what are the things that can be done immediately, as before they actually get to specialist help?
So thank you very much. No, thank you, Dr. Devitya, and thank you, Marcella, for a really wonderful and very informative talk that had every ingredient in it. And as you were saying, before in the pre-meeting, mental health, often people think last of all, but they should first of all. And Dr. Devitya, that is the most important thing. Is so, of course, we have to concentrate on the physical health of patients, but we know now that patients who are in ICU, they are likely to suffer, most of them are likely to suffer during their term in ICU. 30 to 90% of them will have delirium, which is obviously a serious medical complication. And a large number of them will also have, the statistics are still coming out, but probably about 30 to 40% of them will have other major complications like anxiety, depression, insomnia, suicidal ideas, and alcohol misuse. So that data is already there. So patients and carers suffer different things. Carers will suffer a lot of intense anxiety, can't see their relatives, can't go near the hospital. Are they going to be able to ever see them when the relative dies? Obviously, it becomes just very difficult for them to grieve properly. Now, the staff suffer different things. So staff see their patients dying. We always try and save lives, but ICU doctors and nurses have had to contend with patients dying. And that bed, as soon as it's empty, another patient's coming in, you haven't even properly grieved yet for that patient, and the bed's ready to be filled. And what has been described about this is moral injury, first described in soldiers, but now we know that healthcare staff on the front line have also been suffering moral injury, and you'll hear more and more of that, which is really basically, it's that when an individual's moral conscience, ethical values are breached, so they display a range of emotions from sheer depression and suicidal ideas. And we know one A&E consultant who actually emergency physician who killed herself in New York because she couldn't cope with this moral injury. To the other extreme, which is anger and betrayal of the services, politicians from COVID going badly wrong. So, and I suspect India is no different from this. And what we need to be aware is, look, we've got to put our hands around our colleagues when you see them suffering. Too often we're too busy to do that. And Marcella described a real unit which works together. Everyone is in there together as a multidisciplinary team. And your patients, of course, pick up, there's something called rehabilitation in ICU these days. And if that's not available, then obviously as soon as patients are discharged, then some kind of a follow-up should happen once you know that they are developing mental health problems. Catch them early, treat them early is what I would say.
Thank you, Prof. Bhamra. So, Dr. Marcella, so, you had a fantastic bioinformatics team, and you had an EMR, so the electronic data which was captured as it sort of happened. And, all systems may not be as sophisticated as the one you developed. So, is it possible that even on a normal ward round, if we just looked at the sort of parameters that you described, a CRP or a D-dimer, and you could sort of, on a ward round, could you traffic light such patients and, allocate them to higher or lower levels of care? Or how would you do it in a less resource setting?
Okay, that is a very good question, actually. One of the things is just to put you into context, we got two hospitals under the same umbrella, in the same trust. So one hospital was on the EPR system on the first wave, and our second hospital was still on paper. But all the patients' data was coming into the EPR, but because they were not live, clinicians were not able to see it. So the way that we did was people that were self-isolating were responsible of checking the dashboard for the sister hospital and then ring and provide information to the front-end clinicians so they could modify treatments. That's one. Secondly, for hospitals where they don't have an electronic medical record, that's a reason there's a traffic light. They can print it out straight away, look at the variables, and make decisions at the point that they review a patient. So you can adapt the system and can be used from a medical student point of view. They can actually do their own rounds, check the blood results, pick up, create a list of all the patients that highlight high risk or suspected risk, and then meet with a junior doctor or the consultant in charge and say, I done my round, I found all these patients. What would you like me to do? So then it was, okay, this one, they will review and they can make decision. Okay, go and make sure that the anticoagulation is actually at the right level, or go and make sure that the patient is well hydrated, or make sure that the patient receives antibiotics or do a culture. So it's a system that is so easy to use that you don't need to be a senior clinician. It's a system that allows you to manage patients' volume efficiently and safely. And so in that way you can keep the moving patient forward and stop progression. That's kind of the objective of this type of systems.
So one more question, Dr. Marcela, is, the third leg of your thing was on infections, ARDS and infections. And what is your experience about long-term of nosocomial secondary infections after a long stay in the ICU? For example, in India, we've seen mucormycosis suddenly come up in this wave, not so much in the first wave. So what is your experience about bacterial and other secondary infections?
Yeah, that is a very good question. And that's the reason I separated the data quite well between first and second wave and before and after the introduction of dexamethasone. So what we see, we haven't seen as many infections on the first wave. The second wave, we got a lot of patients with bacteremias and patients with ventilator-associated pneumonia. And again, we could easily say this is because of the dexamethasone, but we can convert that to something different. That is, because of the dexamethasone, we save more patients, and only the one that couldn't make it end up in ICU because they got more impaired immune system for whatever reason. So it's very tricky to blame a drug that helped us to reduce the hospital mortality dramatically as the drug that actually is the cause of infection in ICU. That I think that the patient is kind of self-selected, because you treat more patients and more patients respond to treatment, the one that ends in ICU are the sickest and the one more prone to infections. And that may be the reason, but we need to wait for more studies to come and show us objectively if this is our impression.
Okay, so dexamethasone is saving patients, but maybe we're also seeing, because they're surviving longer, and maybe we might be seeing some of those sort of situations.
A long-term effect, yeah.
A long-term effect. So Prof. Vamra, a quick question to you, if I may. In India, we've had this problem is that, one of the reasons for mental trauma that families are having or may have is, they've been with patients when they're really sick and they've been scouting and looking out for hospital beds and ICU beds. And there's that feeling of helplessness, and, they felt that they could not do enough to get their loved ones into a hospital in time. So how does one handle that kind of guilt or trauma because of such situations?
Yes, so I mean,
patients?
Indeed, and I think well, I think these are all, there are so many moral injuries, not just on us, but also on patients, you see, because patients, the scenes of them not getting oxygen and oxygen being given by community places like gurdwaras, all those pictures have come around everywhere, and the only thing is, I think one of the things about India, I remember from medical school days, and still have very strong connections with India. India is a very tolerant society. India is a very communal society, and I would hope that there will be that togetherness that will bring people to come to terms with it. The worst thing is people not talking about it, because these are very difficult scenes. All those scenes that we've seen are so difficult, but people are very communal. They still live in family networks. The focal point is still the community place. That might be the mosque or the temple or the gurdwara or the church. And all these places need to get together, combine together to form a healing circle. Not many of them will need actual formal psychiatric help, but of course we know that suicidal thoughts and deliberate self-harm is very, very prevalent in these communities. And of course, you will have heard about the post-intensive care syndrome, which is more likely to occur in patients with COVID. And of course, in India, you will see large numbers of long COVID patients also. So it's going to be a lot of it has to be done by the politicians and the media, because we have to have the right messaging so that people can get that support that they need.
Okay. So I think
sorry, that's me. If I may, I think that one of the key points Prof. Banra said is communication. It doesn't matter. It's about giving people the opportunity to discuss, to share their experiences, because it's from the moment that they take out of their mind and they share it, they can together find a solution or trying to mitigate the impact of it. And of course, there will be a group of patients or people that will need a special support, and that with a follow-up that can be addressed. But it's about stimulating the community to talk about it. There's nothing wrong about it. And that is kind of one of the things that help a lot.
I think talking about it may help quite a bit. And I think what this pandemic has done in India is, of course, it's exposed the holes in our healthcare system, but it's brought out the best in the community response. We've seen some fantastic response from different social organizations, from different communities, the corporate sector, and of course our friends like the PAPIO from India, from UK and other countries. So I think we've grown together, and I'm sure we'll get out of this situation together, and I'm sure we'll eventually do well. So how effective is telemedicine for psychiatric health? And Dr. Marcela, how effective is telemedicine for treating patients at home while they are actually getting sicker, while they are also both situations? What is the role of telemedicine?
I think it has a role, and we have developed a virtual hospital actually. So we have a virtual hospital that connects to nursing homes, and so where we can actually go to a system that when having high temperature or criteria for the deterioration, those patients are flagged to the matron or to the person that's running the nursing home, and they communicate to our emergency department, and depending on the physician, that patient is brought into hospital or not, or advice is done on the phone. So we currently run virtual hospitals, and we got a virtual clinic for patients not only COVID, but non-COVID. So Dr. Sadia Khan is looking into patients with congestive cardiac failure, patient with AF. So there's a lot of work about virtual hospitals in our organization and across England. The other, what we started running because of COVID is a virtual psychology clinics. So all our patients are followed up by the psychologist virtually, and it's well accepted. And it's, again, I say well accepted in the sense that when the research nurses do the follow-up clinics, they actually get the feedback about the psychologist that was on the phone previously. So it's kind of a nice mechanism. So there is some objective data out there that the patients are satisfied, because patients are scared of coming back to hospital.
Bhamra, your experience with dealing with psychiatric illness and patients,
Yes.
families, health staff on
And
teleconsult?
it's well, and you know, we're in a different world, aren't we, Dr. Devitya? We're now in a world where telemedicine is going to transform the way care is going to be delivered. And for India, that is a big plus because we can reach into remote areas once broadband and Wi-Fi is connected everywhere, and you know that's the ambition. So I would say two things on telemedicine. So Bapio is first of all launched an iPeer support, so anybody can Bapio website, go to the Bapio website and contact us. So we support Indian health workers. We don't treat Indian patients, but we support Indian health workers, doctors, nurses, pharmacists, and very happy to do that. And the other thing is Bapio in conjunction with GAPIO, Global Association of Physicians of Indian Origin, and British Indian Psychiatric Association have also launched support. These support sessions happen about 3 or 4 times a week. So very happy to give more information. In fact, a lot of information on our website. The other thing is, of course, that I'm also part of a board of Center of Innovation and Biodiversity, which is launched by the Government of India last year by Harsh Vardhan, your health minister, and Varinder Garg heads that at the PGI. So he's launched teleradiology to reach out to rural communities, which is fantastic as well. And of course, we do at Bapio teleconsultations with hospitals and rural practices, medical practices, which is also launched, which is also supportive, and it's done by Professor Parag Singhal, a physician. So there are so many things that are being done just now. We just need to keep doing more, I think.
So I think this has been a fantastic learning session. I think Dr. Marcella has shown us how we can organize things well, both in the hospital and have a network, an organized network from the home to the community to the hospitals. And then in the hospitals, you have this traffic light system and classify and categorize patients and target them early as soon as you catch them in the right locations at the right time. And of course, mental health has shot into prominence, and I guess that's going to continue long after this pandemic dies down. And we are going to need the help of mental health professionals to help all those who survive the disease and those who've taken care of patients and their families and so on. And telemedicine and Zoom has boomed in this pandemic and helped us connect with each other. And thank you very much for being with us, and to Deep and the British High Commission and NHS for organizing this wonderful series. So Deep, I think we can.
Thank you so much. Yes.
This wonderful session.
Thank you so much, Dr. Devitya. Let me congratulate for the wonderful and fantastic presentation and a very useful and very interesting conversation after that, which was, really required. And, on the behalf of our viewers, participants, the whole organizing team and British High Commission, I would like to extend our sincere gratitude to our speaker, moderator, and the panelists. Thank you so much for joining here today and spend your precious time with us. We hope to see you in future and wish you all the very best. Thank you so much. Before we move ahead, I would request Vinisha to show the indemnity slide if possible. Thank you so much. So this is very important disclaimer. These knowledge exchange series contain general information about medical condition and treatments. The information is not formal clinical advice and should not be treated as such. The medical information provided without any representations or warranties express or implied. We the NHS make no representations or warranties in relation to the clinical information offered. You must not rely solely on the knowledge exchange sessions as an alternative. If you have any specific questions about any medical matter, you should consult other professional healthcare colleagues. It is important to understand NHS healthcare professionals are providing their own NHS experience and their own knowledge on the management of COVID-19. The duty of patient care will remain the responsibility of colleagues, clinicians in India. NHS organizations, NHS bodies, NHS workforce will not take any direct or indirect responsibility of patients who are not under the direct care or supervision. And thank you so much, everyone. Before we move ahead, last announcement for our colleagues who are joining through YouTube. I wish to announce that we are holding series of webinars on every Saturday at 6 p.m. And if you or any of your colleagues wish to learn more about COVID management, I would encourage you to join our session on Saturday. At the same time, on every Thursday, we are hosting open Q&A sessions where our Indian clinicians are welcome to join and ask any question related to COVID management. The next week, our topic will be the management of COVID-19 in pediatric patients, which is the most burning topic at this point in time. And thank you so much once again for this. With this, I think we can call it a day. I would thanks once again for joining us, and have a great evening, afternoon, everyone. Take care and bye-bye.
Thank you so much.
Bye.
Bye-bye.